Hey, future health heroes! Get the study guides and tips you need to ace your nursing exams. Follow us for more.
Have you ever watched a detective show and wondered how they piece together all the clues to solve a complex case? Well, that's exactly what public health experts do every day, and their science is called epidemiology. So today, we're going to put on our detective hats and learn the fundamental principles that public health nurses rely on to protect our communities. All right, so here's our game plan. First, we'll get clear on our mission as disease detectives. Then we'll figure out how to size up the scene of an outbreak. After that, we'll track how it spreads, measure its impact with some key numbers, and finally, we'll look at our most powerful tool, the diagnostic test. Okay, first things first. Every good detective needs to know their field, right? For us, that field is epidemiology. But what actually is it? Really, what it boils down to is asking some fundamental questions. Who's getting sick? What is making them sick? Where is it happening? And, the big one, why? This is the science that lets public health nurses go from just reacting to crises to actually getting ahead of them and preventing them from happening in the first place. Now, let's get to our first real task. A report comes in. The very first thing a detective has to do is figure out the scope of the problem. Are we looking at a small, local issue, or is this about to become a global emergency? You know, some diseases are just always kind of there, like the common cold, popping up every winter. That's what we call endemic. It's the normal, predictable level of a disease we expect to see. It's our baseline, and it doesn't usually ring any alarm bells. Now this is when things start to get interesting. An epidemic, or what you might call an outbreak, is a sudden spike. Let's say a town that usually sees maybe 10 flu cases a week suddenly reports 500. Whoa, that's an epidemic. It's a huge red flag that something's changed and we need to act fast. And what happens when that epidemic breaks out of its borders and starts spreading all over the world? Well, that's when it becomes a pandemic. This is the highest level of alert, the kind of thing that demands a massive, coordinated response from the entire global community. So, to get our investigation organized, we use a classic tool, the epidemiologic triangle. It's simple, but it's powerful. It helps us break the problem down. First, the host. Who is getting sick? Are they young, old? Do they have pre-existing conditions? Then we look at the agent. What is the culprit here? Is it a virus, a bacteria, maybe a toxin in the water? And finally, the environment. Where is this all going down? And what conditions are allowing the agent and the host to meet? Think things like mosquitoes, contaminated water, or even crowded living spaces. Okay, so we've sized up the scene. Now we've got to figure out how our culprit, the agent, is getting around. We need to understand its mode of transmission. We can pretty much break this down into two main lanes. Direct transmission is, well, it's direct, person-to-person physical contact. But indirect transmission, that's a bit sneakier. The agent uses a middleman, like a contaminated doorknob, a mosquito carrying a virus, or even tiny infectious particles just hanging in the air. Now, this is a big one. It's a critical idea and a classic trap that every detective needs to avoid. We might find a link between two things, an association. For example, maybe studies show that people who drink a lot of coffee tend to live longer. Okay, that's an association. But here's the million-dollar question. Did the coffee cause them to live longer, or is there something else going on? So here's the takeaway. A connection isn't proof. An association is just a clue. It's not the smoking gun. To prove that one thing truly causes another, we need a lot more evidence from really well-designed studies. To build a solid case, we can't rely on gut feelings. We need hard data. This is where we get into a few key numbers that are absolutely essential for core public health functions, like community assessment and making sure our interventions are actually working. First up is incidence. You can think of incidence as the speedometer of the outbreak. It tells us how fast new cases are popping up right now. For a public health nurse on the ground, a high incidence rate is a 5-alarm fire. It's the data that says we need to act immediately. Prevalence, on the other hand, gives us the big picture. It's a snapshot of everyone who has the disease at a single point in time, both new and old cases. This helps us understand the total burden of a disease on a community, and it's the number you use to plan for long-term resources and advocate for health policies. And here's how we actually use those numbers. Let's say there are 30,000 new AIDS cases in a population of 300,000. To make that number meaningful, we standardize it. We divide the new cases by the total population, and then multiply by 100,000. That gives us a rate of 10,000 new cases per 100,000 people. Doing this lets us accurately compare outbreaks between, say, a small town and a huge city. All right, last but definitely not least, we come to a detective's most powerful tool, the diagnostic test. But here's the thing, not all tests are created equal. Their power comes down to two really important measures. A test's value really hangs on two things. First is sensitivity. That's how good the test is at correctly finding people who do have the disease. A highly sensitive test catches almost every single case. Then there's specificity. That's how good the test is at correctly clearing people who don't have the disease. A highly specific test doesn't give you a lot of false alarms. Okay, let's make this real. Here's data from 1,500 people who got both a rapid test and the super accurate gold standard PCR test for COVID. You can see the numbers for true positives, where the rapid test got it right, false positives, true negatives, and false negatives, which are the cases the rapid test missed. So when you crunch those numbers, here's what you get. The test has an amazing specificity, almost 100%. That means if you test negative, you can be really sure you're in the clear. But its sensitivity is a bit lower, around 81.5%. That means it's going to miss roughly 18 out of every 100 people who are actually infected. And that brings us to a really tough question, one that public health leaders face all the time. If you're dealing with a really dangerous disease, one that spreads easily and has a high mortality rate, what do you prioritize in a test? Do you want one that's better at catching every case, even if it means some false alarms, or one that's better at clearing healthy people? When the stakes are that high, the answer is almost always sensitivity. You have to prioritize catching every single possible case. Why? Because the danger of just one false negative, one infected person who thinks they're fine and goes out into the community, is just too massive. It's better to have a few false positives that you can double-check later than to miss one case that could spark a huge outbreak. And there you have it, the basic playbook for thinking like a disease detective. From defining the problem to tracking the spread to using the right tools to uncover the truth. These are the fundamentals that help public health professionals keep all of us safe. So the only question left is, with this new toolkit, what mystery would you want to solve first?